What is your final slide? What is your final slide?
最后一块那边。
Okay, 我看一下。
Oh, this is the last one.
Yes, this is the last one.
Okay, you want to ask us regarding this? I think, if I may, I think if you have this situation, I think because you have seen the huge elevation of interleukin-6. When possible, I think we had in our hospital in Hefei, we treated 14 patients with elevated interleukin-6 with one antibody, this tocilizumab, and all the 13, I think they get a good result. Because this antibody could really eliminate the inflammatory factors like interleukin-6 and so on. And I don't think you use this kind of medication, but I think this is we start the study on the 5th of February, and the first case enrolled on the 15th of February, I believe. And afterwards, we enrolled 14 patients in Hefei, and afterwards we introduced this medication to Wuhan. I think the version 7 of this guideline, this using this tocilizumab, this interleukin-6 antibody was introduced in the final version of treatment of COVID-19. This may be an option for this inflammatory storm, or what we can call. Okay, thank you very much.
Just one or two other questions I have that I'm hearing from others as well. So one question is, we believe we'll face the similar situation. You have many people coming in. How do you triage? Because you, at some point, you must have had ICU beds full. And how did you make decisions about triage? This is a very difficult question. And also, ventilators may have been in short supply. So how are you deciding criteria for use of ventilators and so forth? Can you share anything about what it was like on the front line when there's overwhelming amount of need and limited resources?
Junior, please give some comment, answer this question, because I think 80% of all the cases that do not necessarily need this ventilation. Only less than 20% they are severe case or risk case. And please give a comment, Junior, in which kind of situation you're using the mechanical ventilation.
Yeah, sure. Thank you for your question, Harlan. And thank you, Dr. Ger. We have some cases. I fully agree with Dr. Ger that around 20% of the patient can develop into a very critical, severe type of COVID-19. And this kind of patient, most of them need the ventilation. So for what kind of patient need therapy of the ventilation? I think it depends. Firstly, the symptom. Some of the patient, you see that the oxygenation index is kind of good, but he has a very, very severe short of breath. So in this case, you should think about that the patient may need a support from the ventilator. So this is the a symptom. Secondly, but I think the most important signs for the support of the ventilation is the oxygenation index. If the oxygenation index is lower than 200 mercury, I think you should think about that. Maybe that may lead to the ventilation, but it's still lower, like 100 mercury, then the ventilation is not enough. Sometimes the patient need a ECMO and the air support. So it depends on the symptom and depends on the oxygenation index. Thank you.
Thank you.
Hala, may we continue to the next topic and we put the discussion at the end. I would like to invite Professor Zhou Ning to present the practical experience with ECMO and mode. Professor Zhou Ning, please.
Okay. Can I share my screen right now?
Yes.
Okay.
你分享屏幕。
Okay, I'm doing this. So full screen. Okay, good morning, Harlan, and good evening, everyone. Dr. Ge, Dr. Ho, and Dr. Huang, and everybody. So I'm Zhou Ning from Tongji Hospital, Wuhan. So I worked as a attention physician in the division of cardiology, Tongji Hospital. Since the early of February, I have worked in the ICU ward in Tongji Guanggu campus for over 1 month. I have some lessons and also some experience want to share with you guys about the treatment and the diagnosis, also the diagnosis of the COVID-19. The topic I would like to share with you is the application of ECMO in a very critical, severe COVID-19 patient. And the first slide. Don't move.
你往下走，我就继续
Okay.
control。
So this is my city. I think Wuhan city is not so well known before, but now is already known by everybody in this world, because in the end of last year, Wuhan is the epicenter of the COVID-19 epidemic, and my city was locked down in January 23 in 2020. And my city is in the central China. About the population is around 12 million, and is also a commuter area of China. So in my city, the new cases is less and less. And today I would like to share with you a very good news that the new confirmed case in Wuhan is 0. That's such a good news. But it's so bad to see that all over the world, the new cases is getting more and more, and the mortality rate is still very high. The cure rate is not so, ideal. So this slide, I should say that I fully agree with Dr. Ge that the 20% of the COVID-19 patient may develop into a very severe or critical severe type. This is version 7 of the guideline for the treatment of COVID-19 in China. It says that the patient met any of the following conditions might be the critically severe type. The first one is respiratory failure requiring mechanical ventilation. So the first one is ventilation. Secondly, the patient have a signs of shock. That means the blood pressure is lower. And third, the patient combined with other organ failure needed the ICU monitoring and treatment. So unfortunately, I worked in the ICU ward. So most of the patients in my ward are the critically severe type of the COVID-19 patient. So as I said just now, that most of the patient needed the ventilation to overcome the hypoxemia. But what if the patient still have a very severe hypoxemia on ventilation? What should we do? How can we save the lives of this patient? So answer is ECMO. I know that everybody know ECMO. ECMO came to China around 20 years ago, and we know that there's 2 common mod we use for the ECMO. One is a VV ECMO, and another one is a VA ECMO. So I would like to share a typical ECMO case with you and to express my opinion about the application of ECMO in the treatment of COVID-19 patient. So this is a male patient, 50 years old, and admitted on February 11, 2020. So the chief complaint is fever for 11 days and short of breath for 2 days. The present medical history is fever, and the maximal temperature is around 39. And he has a very shortness of the breath in recent 2 days. And the past medical history is very good. It's very healthy before. And the epidemiological history that the patient is a resident of Wuhan city. So he lived in Wuhan, and he has a very close contact with the other confirmed case. So this patient is a very typical COVID-19 patient. And this is we got a physical examination for him, and the SpO2 is around 75%, is very, very low, and the heart rate is around 92. The blood pressure is kind of the 130 and over 86, and the respiratory rate is around 24. The temperature he was admitted is normal, and the clear mind, passive position, and no other positive signs. This CT scan image showed that the patient, when he was admitted to our hospital, look, this is a very, very typical signs of the virus pneumonia affected by the COVID, the new coronavirus. And this patient has a very severe hypoxemia and respiratory failure. We get some lab tests for him. The CRP, the kidney function is kind of normal, and the LT is a little bit higher, ST higher a little bit. But what caused our attention is the lymphocyte. We know that the lymphocyte is a very important biomarker of the patient, whether he might be developed into a very severe type or very critically severe type. If the lymphocyte rate is extremely lower or significantly lower than normal, that means the prognosis of this patient is very, very bad. We should pay 100% attention to this kind of patient. So as the ABJ shows that the patient is short of has a kind of normal pH and PO2. The PO2 is lower. Actually, is lower, and SpO2 is also lower. This is the test for the patient under a support of a BiPAP ventilator, and also the BMP is higher. The troponin I is higher. So that means the patient has also a myocardial injury. And here we showed the echo that EF is around 45%. For a patient is only 50 years old, that this kind of EF ejection, that's pretty bad, right? So we get some treatment for him. Also the antibacterial, antivirus, we also use Avidol and some kind of Chinese traditional medicine, and relieving the asthma and resolving the phlegm. So and get some support like the nutrition and also some kind of the Chinese traditional medicine. But it's getting worse. He's getting worse. The hypoxia was getting worse, and he was transferred into the ICU. This X-ray showed was did before he get into the ICU. Look, it's very typical ARDS. So in this condition, the patient definitely has a very, very shortage of the oxygen. So we transfer him into the ICU. And in this case, in a very, very severe hypoxia, we get the endotracheal intubation for him to get the support from the ventilator. And we also did some prone position ventilation, and the oxygenation index is lower than 100 millicurie. So that means the hypoxia is very, very severe. So in this case, and look, the laxate is very higher. Also means the shortage of the oxygen is very severe. So that's another choice. Maybe that is only choice for the treatment of the patient. Initial parameter for this patient is the speed is over 3,000 road per minute, and the flow is 3.2 liter per minute. And we got the oxygen is 4 liter per minute, and the concentration of the ECMO is 40%. So this is picture. The left picture shows that we just finished the ECMO, VV ECMO for him, and this bedside. And the right one is the heart rate, the blood pressure, and also the SpO2 just a couple minutes after the implantation of VV ECMO. That means the ECMO helped him a lot, and also almost remove the hypoxemia for this patient. And remember the date that we did the ECMO for him at the February 18, and this is X-ray of the February 26. Look, it's getting better, right? It's getting better. So the shadow is less and less. And this is February 28, getting better and better. And the last one, the right one, is X-ray before after we remove the ECMO. So we not only we did the ECMO for him, but also we did the blood purification for him, because we found that the CRP of this patient is extremely higher than normal. That means there is an inflammatory storm occurred in the body of this patient. So we did the blood purification and the ECMO and to help him to survive. So we did the ECMO for 10 days. The duration of the ECMO is 10 days, and this and the CT of the left is before the implantation of VV ECMO, and the right one is after that. Get much better, right? So get much better. So we did some, actually the other treatment, the antivirus, the antibacterial are almost the same before we get the implantation of ECMO. So that means why the patient get better is not because of the drugs. It's not due to the medications, but the patient recovered by himself. We just give him a chance to get recovered. And this remove the ECMO at February 27, and he get. I shout that you get back, you survived. He's very happy. And this morning, I went to the ward to see him. Look, this is the patient. This is the first ECMO case we did in my ward. That's in February 18, and he get a very good recovery. And he can eat, he can work, he can do everything that we can do. So we're so happy for him, and he will be charged tomorrow. So far, we have finished 5 cases, ECMO cases in my ward, and 4 of them have finished and get recovered, a very good recovery. And right now, currently, we have one more case who is getting the support of ECMO is ongoing. Among these 5 cases, 4 male and 1 female. And all of the ECMO, we have 4 VV ECMO and just 1 VA ECMO. And the average age of this patient are 55.6 years old, is range from 44 to 68. And the duration of the ECMO is around 9.2 days. The longest one is 13 days, and the shortest one is only 6 days. So that's 5 cases finished so far. So actually, we get some lessons and experience from these cases. So first one is indication. When do you use the ECMO for the patient? What kind of patient needs the support of ECMO? So traditionally, we think that the critically severe respiratory failure and hypoxemia with oxygenation index lower than 100, the patient need a support of ECMO. But I don't think that is always right. Just think about that. For a very young patient, for a very young COVID-19 patient, has a very low, but not so low, a kind of 100, around 100 to 200. But you can predict that he cannot recover from the lung disease in a very short time. That means in this duration, in a very near future, the patient will be suffered from a very severe kind of the hypoxia. If a hypoxia prolonged for too long time, that means the other organs will be damaged by the hypoxia. It will cause MODS, including the heart failure, like the cases presented before, heart failure, kidney failure, liver failure, and also DIC. If the patient get all of these organ failures and you did the ECMO for him, that doesn't help. That's why so many patients get the treatment of ECMO, but few of them can be withdrawn from the ECMO. That means what I said is we should think about the support of ECMO in advance before he gets the MODS, before he is dying. Don't do ECMO for the patient dying. That doesn't help. So that's the first point I would like to say. second one, what's the contraindication? So which kind of patient cannot get the support of ECMO? For example, MODS. I don't think ECMO helps the patient recover from MODS, especially for those have 3 organ failure, like the heart failure, DIC, liver failure, and kidney failure. For this patient, the ECMO maybe cannot help them so much. And also bleeding, like DIC, because we need to do the heparin for this patient, a continuous heparin for the patient. The anticoagulation, we can't do that because the patient has a bleeding. The third one is a reversible severe brain injury, and also the elder. I don't know whether you recognize that all of my patients are not so old, is younger than 70 years old. I don't think, but for some case, I read some case report, they did the ECMO for a very, very old patient, like 80s and 90s, but most of them cannot survive. In China, right now, we don't have so many ECMO system. We don't have so many, the resource for all of the patient. We need to choose. We have to choose. We have to choose some patient who can properly recover from the COVID-19. So for those patient who is younger, he has maybe higher possibility to get it recovered. So I don't think that we need to do too many ECMO for very old patient. And the third one, I think that's the most important one, is opportunity. When, who, and then is when. When should we do the ECMO for the patient? I'm not sure whether the earlier the better is right. Yeah, maybe I need to ask somebody, ask Dr. Ger to get a more wiser suggestion. But for me, in my word, I think if you think the patient is probably to get a support of ECMO, do it earlier. Don't wait. If you wait, you lose the opportunity, you lose the chance, especially for those very young patients. So I think that is earlier, the better. The later, the worse, especially for those young patients. So the ECMO, so I always say that the ECMO is not for the prolonging life for days. It's not for the just prolonging the life for a couple of days. That has no meaning, right? So it's an opportunity for patient to survive, to recover from the very critical, severe COVID-19. You get a chance for him. He has a chance to get recover. Who can kill the virus by himself. He just needs a couple days, need an opportunity. So that's what the ECMO can do. So the third is the mode. So the first choice absolutely is a VV ECMO, but sometimes if the patient have a very mild heart failure, and you think you should get support of heart, so the VAV ECMO maybe is an option. But the last choice, the last option is a VA ECMO. The VA ECMO is usually used in our department. I'm a cardiologist. I work in CCU. So the VA ECMO is commonly used in CCU, but not in the world for the COVID-19 patient. For the COVID-19 patient, absolutely, we need to choose the VV ECMO first, and then think about the other mode. So this is the fourth. The third one, though, is very, controversial. For the expert in the field of respiratory field, they think that the intubation is the first choice for the patient who has a respiratory failure. But for me, I'm not an expert in the respiratory. I'm just a physician. I think traditionally we think that the intubation is first, and then think about the ECMO for the patient with a very severe respiratory failure. So that's the traditional opinions. And remove the ECMO before, remove the ECMO firstly, and then remove the intubation. This is a traditional opinion. But how about the use ECMO first? Or even we can go further. We use ECMO without intubation. That means we can use ECMO to support the lungs and to remove the hypoxia without the intubation and the ventilation. For this patient, for the COVID-19 patient, I mean, the exchange of the oxygen is too bad. It's very, very low. The ventilator cannot help a lot about the oxygen exchange, but the ECMO can do that for them. The ECMO can exchange oxygen outside the bodies, so it can relieve their hypoxemia, and also the sputum. We have a lot of the liquid in the lung. It cannot be cough. The patient cannot cough if he is intubated. So that's another shortage of for the ventilation. So I'm trying to do the ECMO only without the intubation for the very critically severe patient. So we already finished 3 cases. In these 5 cases, there are 3 cases. He removed the intubation first, and then continue to use the ECMO to support the supplying of the oxygen. So that's for this. So I would like to say thank you to my patient. They are the hero of my city. They fight against the virus, fight against the COVID-19 together with their bodies. So they are the heroes. So these 5 cases I did in the last 1 month. Number 1, number 2, number 3, number 4, and the number 5 is still ongoing for the ECMO. We just removed the ECMO system for the number 4. The patient number 4 is a lady, is 58 years old. And also for guidance from Dr. Gerjunbo and the CCA, and from friends and some organs overseas, and from my hospital, Tongji Hospital, we try our best to save lives. And also say thank you to my family for not staying with them in this very special period. Thank you for your attention.
So, Junior, thank you very much. Really, I think you deserve the salute for us. I think you did a very nice job in last more than 1 month. And now I think we began for the discussion regarding the last 2 presentation, and we can ask other questions regarding this COVID-19. 不是霍勇，你what would you see?
Yes, Dr. Joy really gave a very good presentation. In his appearance with ECMO, I think as a concept, it is quite reasonable, especially for the situation scenario in the ICU. You get a lot of the patient with a severe condition. So you want to have an ECMO early stage and prevent to the severe stage. So I think that's a concept is quite reasonable. But actually, we think if we found some cases with ECMO not to have a very good outcome, patient eventually get to die. But mostly, I think it's late. It's a very late stage for the ECMO. So maybe his lesson is the early the better. I part of agree part of his opinion, but actually I think ECMO we still face a lot of problems because first is a shortage of supply. Actually, we only few available for the ECMO machine, and also technical programs and also staff. So for reasonably, I think for the COVID-19, we still think step by step from intubation. So this is your second point. I think intubation still sometimes has a first choice before the ECMO. But sometimes if patient have a very late stage of COVID-19. That means maybe they have a lot of some infusion in the lung. Maybe you cannot have a incubation works. So maybe you should have an ECMO. So this kind of judgment for the patient, how benefit more from ECMO or from intubation, from airway management. So these are very good lessons. And also I found we have some questions from our audience, from our audience for ask the same question for the VV mode and the VA mode. From your experience, the 4 cases of VV mode, only one case VA mode. And also our audience asked the VA mode can be supplemented, or sometimes you don't have a ECMO, they can use like IABP, like Impella. So you can ask answer the question that our audience ask. That's very important, especially from some area they don't have a ECMO used, not available. So there's a question for the Dr. Zhou.
Sorry, I can't hear very clear. So my internet was not good.
Just the question from our audience ask you what's the indication for the VA mode, especially your one case with a VA mode, how to choose that.
VA.
The second question is not available. ECMO is not available. Sometimes it can be use IBP or Impella if IBP Impella is available.
Professor Ho, before Professor Zhou answer this question, I just would like to do some comment, because in the early phase, we do not not all the centers they have the ECMO system. The ECMO was delivered in the middle February or so on, I think, to Wuhan, because in Wuhan we have limited the number of ECMO. This is first. Therefore, only in the second phase we are able to implant ECMO for some high risk patient. This is the first situation. Secondly, and I do believe most of the ECMO mode was a VV mode, because we use the patient get hypoxemia. To improve this hypoxemia, I think VV ECMO is more than enough if the patient has a good cardiac function. We do not recommend VA mode, because the VA mode will increase the afterload. For the VV mode, we have the blood from the inferior vena cava, and we get the saturated, and we give it back to superior vena cava. If the cardiac function is normal, I think this is enough for it to help. For the VV ECMO, ECMO, we have the blood, saturated blood to the artery, and this may have this risk that they increase the afterload. For patient with decreased cardiac function, it will be even becoming worse. The ideal way would be, for example, with patient with heart failure and hypoxemia, we're using VV ECMO and Impella, because Impella could replace some of the heart function. But in the ICU, it is nearly not possible. It's nearly not possible. For example, by this Impella, we need normally do in the cath lab first. Secondly, during the implant of this device, we have to wear 3 or 4 gloves, and with this mask, and you have no feeling of to puncture, find the vessel. Therefore, it is extremely difficult or not practical for this implant, these 2 devices. I think what Professor Zhou mentioned as the earlier the better is, we have to interpret which kind of patient would develop to a critical phase. And before the patient get the respiratory failure, we implant the ECMO. This could save the patient. Once the patient gets really multi-organ failure and ARDS, and especially by the elderly patient, it is really, really sometimes not helpful. So, Professor Junior, the question come to back.
Okay. Oh, go, I'm sorry.
周年还有什么补充吗？刚才葛院士讲完。
葛院士把我想说的都说了。I don't have
Okay.
any more comments.
I've got a few questions for you. And some are coming from people who are also sending me questions. So let me send them to you. But one question I have is, did you develop or can you develop, based on your data, a risk score, a way for us to dynamically estimate people's risks so that we can know that this person may be early, but that they are very likely to progress to a worse situation? Because I feel this is a perfect situation for not a static risk model, not something on admission, but something we're updating in almost real time as new information comes along, so that we can know that this patient is on a trajectory. And if because otherwise we don't know if it's early going to something worse or it's early, not early at all. Actually, we're at the end and they're about to turn the corner and get better. So I just wonder if you can share first, this is my first question, whether you have experience with dynamic risk scores and what we can learn from you from that. It's, by the way, also questions we've had here about inflammatory markers and other predictive biomarkers that you might be using to help you understand how the risk is changing for a particular patient, besides what's obvious. Thank you.
Right. Huang Kai, again, Professor Huang Kai, Professor Junin, because you're working in front line, do you have any comment on this dynamic factors?
Yeah. You mean that for the ECMO, or maybe just
No. Alan mentioned how you judge the patient from the light case to the severe situation to the risk situation. Is there any parameters?
Oh yeah. What I think is that for us, we just monitor the oxygen, the concentration, and then we just to check, to test the blood CRP levels, and maybe to see if it's increased very high, and especially we monitor the liver function and the kidney function, because many pneumonia patients and with the multiple organ dysfunction, well, in this case, so maybe they have the liver dysfunction, or maybe they have the kidney dysfunction, and in this case, we will transfer the patient from the normal case to the ICU or something like that, and for now, and what I think is that can I talk about the NAST patient. What I think is that the NAST patient, they show us, I think, the very possible diagnosis is that maybe the patient has the pulmonary infection induced, then the BNP increase, and maybe I think according to the pathological, report from the non-tissues, they found many cases with the pulmonary hemorrhagical infection. So I think that that very fit with the increased the dimer, and maybe the increased the pro-BNP, something like that. So that was my comment about the NAST patient, and and then so that's what I want to say.
So let me just go through a couple of other quick ones. But with regard to that, I wonder if it's a good moment, as the volume has dropped, to be collaborating with data scientists around the data that you generated on every one of the patients, to help us be able to develop risk scores that can be updated. And then we can, Chinese colleagues can share those because you have the deepest and most extensive experience. And so then we can turn that into ways of predicting for patients and being able to risk stratify them in ways. Another comment is, I think on the last patient, again, it impresses me about the multi-organ failure. I mean, I don't think it's it's not a cardiogenic shock. You have the ejection fraction is 45%, but you do have a myocarditis, it seems, because the troponin is up, the BNP is up, but it likely combination between respiratory failure and also cardiac dysfunction and a wide range of others in this inflammatory storm. So in ways, I think for the audience to think about ECMO, I mean, it's not, it falls in the middle. I mean, there are several ECMO trials for ARDS, and there are some studies in cardiogenic shock. This is really a mixed picture of things going on in these patients in the midst of this situation. And it will be very important for you to write up your experience at the end so that it's a coherent experience of what happened, because it's a combination. It's a multi-organ involvement, and where you decided and what happened with the patient, I think will be very important. One question that's being asked by one of my colleagues at Yale is about your monitoring of the inflammatory markers. Were you measuring every day? Were you measuring every other couple days? I mean, how did you decide about measurement? And I think this goes for many things. For example, someone comes in COVID negative. Were you measuring then again every day to see if it was actually going to be positive, or did you accept a single initial test as negative? So what was your testing strategy monitoring these patients, and what did you learn through the course of your experience in what strategies seem to be best?
看看周宁跟黄志颖，你们两个回答一下，就是你们测这个血液的这指标，这细胞因子是先测一次，你们都是怎么测？周宁跟那个黄志颖。
I try to answer the question. And for severe patient, not critical patient, severe patient, we always make the laboratory test once a week. And for critical ill patient, we make a test maybe every 3 days.
Which test once a week? You said once a week.
Just for the what the severe type patient, severe case.
测什么？关键是测什么？
You mean once a day, maybe?
Yeah, and it's a blood test for biochemistry. Biochemistry test, CRP, and cardiac function biomarker, and so on.
Once a day, not once a week, right?
Once a week.
Once
a week. Yeah, for very critical ill patient, and just once in every 3 days, make a test. And extremely ill patient every day. And it's the practice daily practice here.
And with regard to your use of immunosuppressive therapy, I mean, how we talked a little bit about this yesterday, but use of, for example, steroids or other treatments. How was your experience with that?
You mean the corticosteroid?
Yes.
Steroid. There is a very debate. It's a debate among the member of our group, our medical group, and I think the steroid, the corticosteroids do have effect on its inflammation. However, I think its drawback is obvious. It can how to say, to delay its clearance of virus.
So you weren't using it very commonly?
Not so commonly. Not so commonly. Yeah, not so commonly, but for some very critical ill patient, where we use corticosteroid.
Okay.
What is the situation in your center, Zhou?
Yeah, very similar to Dr. Huang and Dr. Chao. We did the blood test every 2 days for this patient in ICU, especially for the blood routine test and also for the electrolytes test like the potassium, kind of that. And also we did the inflammatory cytokines test for this patient. As you said, that if this kind of the cytokines gets very higher and getting higher and higher, that's not a good indication. That means the patient is getting worse. That means the respiratory failure may be getting worse. So, as you said, whether there is risk score for us to evaluate that, but you know, if you get a very 信号不好吗？
现在好一点了。
现在好一点啊。Okay. May I just repeat?
Yes, please.
Okay. So.
我想中间也好，或者说黄大夫，你们要想这么想啊。现在呢，大家更多的希望你们得到一些信息。除了你们要查什么，更重要的怎么这个查的这些指标怎么来评估。比如说现在我们重点要讨论这个病人怎么加重了。现在是都不否认这个炎症或者病毒感染以后激发的免疫状态。那哪些指标能够反映出来？咱们什么时间查？查完以后怎么评估？尤其是比如说你说艾克茂，到底这些病人对预设放艾克茂有没有作用？尤其比如刚才讲到激素，你查到这些指标，比如说炎症指标 CRP 高到什么程度，你考虑用激素，或者低你就不用。就是你们把这个问题具体回答一下，谢谢。
That's quite a very difficult question to be answered. So can I say that's a clinical sense? It's clinical sense, but not more than clinical sense. So we need some very quantified data to assess whether the patient needs a steroid. So to my opinion, the first evidence we need to give the steroid for the patient is the X-ray of the CT scan of the lung. If the CT scan shows that the shadow, the lung, the lesion is getting larger and getting expansion, that means the lung, the virus pneumonia is getting worse. So that's one sign for the treatment, for the therapy of steroid. And I think that's the most important. And secondly, how about the respiratory function of this patient? Most important is the oxygenation index. So in my word, if the oxygenation index is lower than 200, that means the compensation of the lung is very bad. That's just one stage we should think about the steroid for this kind of patient. This is the second one. So the respiratory function. And also the third is the lab test.
So let me just keep going on. So
connection. Can you hear me? It stopped.
A little bit.
It stopped.
周宁，你的信号不大好，你得 check 你的信号。
Let me ask
third.
Oh, go ahead if you can.
Yeah.
Finish. I'm sorry.
Yeah. Maybe I have something to talk.
Yes.
Because theoretically, we have many biomarkers to predict its outcome or its progression of the disease. We have made an investigation. We found that the dimer and troponin and CD4 have the predictive value for the disease. However, practically, I don't think it's take effect, because we have seen many patients who have already stabilized for 1 week, 2 weeks, and we think he will be better and better and discharged. However, the disease condition may worse suddenly, may worse abruptly, and even death. So
One
it's
thing
very, very hard to predict the outcome of an individual patient.
One thing I wanted to suggest to all of us is that maybe we can pull together an international group that will bring together common data that we can share across countries, and begin to develop a large database from the different places that can help us understand the differences among the countries, but also some common tools that can help. And we really want to learn as much as possible from your experience. Let me just quickly take advantage of your presence to ask a few more questions I think that are on people's minds. One question also is, we know this very strong relationship between age and risk. Of course, age and risk for every condition is true. Many people have written me and said, well, of course, age is associated with worse outcome, but it's a very dramatic in this condition. And when you're caring for these patients on the front line, how are you perceiving the difference in the way in which the virus is manifesting itself? Is this just that more older people end up coming to the hospital, or are you seeing the disease as being different in older patients? And how did you, what were your lessons about how age and this virus are related? Can you just share your impressions about that from the front lines?
Okay.
According to my experience, well, I think that the old patient is easy to be infected. And the cutoff age, in my opinion, should be 60 years old. And if when the patient older than 60 years old, so and with the cough and the dry cough, and maybe half of them have the fever, and we maybe so in this case, especially in Wuhan, so we strongly suggest the doctor to check them the virus nucleic acid. So and especially in the initial stage, so this can increase the positive the positive finding of of the patients. So what I think is on the other hand, the elder patient usually with very severe condition and severe so and I think the mortality of the elder patient is pretty high than the young guys. So
was it because of the comorbidities, other conditions, or did you think susceptibility?
Yeah, and although many doctors express notice about the underlying diseases, maybe so we also collect some data of the medical history, and we didn't until now we did not find the association between the underlying medical history with the accidents, incidents of the diseases, and maybe the condition, or maybe the severity of the patient. So there is not clear association between the underlying medical histories. So
I would give some comment regarding your question, because we do see that in our this 81,000 of all the infected cases, we do see that minor infants or children get infected, and most of our patient population is by the middle and elderly age. This is the first fact we observed. Secondly, we are not very sure, as you mentioned, if the bad or worse outcome is related to the comorbidity or not, but it seems to be yes. But another aspect is we do see that for the children and for the young infant, we have rarely get infected. It could be get infected, but the population only take a very minor minority of this whole 81,000 patients.
Were you, did you make any decisions about doctors older than 60 years old caring for these patients? Did you try to hold back doctors who are older from being on the front lines of caring for the patients?
Yeah,
I
in my
think,
hospital, yeah.